Welcome to the deep dive. Today we're getting straight into it. We're looking at a specific condition, Alzheimer's disease. We've got a set of, well, basically MSRA revision notes here, and we're going to pull out the high-yield stuff. The goal is to give you a really clear, structured understanding. Think of it as us sorting through the key points for revision, or just, getting properly informed.
Exactly. We'll be covering it all based on these notes. What it is, the causes, the risks, what's happening in the brain.
Differentials, how common it is.
Right. Symptoms, diagnosis, management, prognosis, complications. The whole picture, but broken down so it makes sense.
Okay, let's start right at the beginning. The definition. What do the notes say Alzheimer's actually is?
So fundamentally, the notes define it as a progressive neurological disorder. It affects the brain, leading to memory loss, cognitive decline, changes in behavior too. And a really critical point they make right away, it's the most common cause of dementia.
Okay, right. So that's key, isn't it? Alzheimer's leads to dementia, but they're not identical.
Precisely. The notes are clear. Dementia is that broader term. It's the chronic, progressive, irreversible decline in cognitive function. Alzheimer's is the specific disease causing that decline in most cases.
And which cognitive areas does it hit? The notes must list those.
They do. It's quite wide-ranging. Memory, obviously, language, abstract thinking, motor skills, visuospatial skills, so understanding space around you. Also executive function, like things like planning, problem solving, and personality, social behavior. It really impacts across the board.
Wow. And physically, inside the brain, what's described?
Well, there's progressive degeneration of the cerebral cortex. That's the outer layer. It leads to widespread atrophy, basically shrinkage. And the notes highlight the key players, these abnormal protein deposits. You've got the amyloid plaques, and then neurofibrillary tangles, which are made of tau protein.
Ah, the plaques and tangles. You always hear about those.
Exactly. Plus, they mentioned reduced production of acetylcholine. That's a neurotransmitter, really vital for memory and learning.
So these protein buildups are actually damaging the cells or stopping them working properly.
That's the idea, yeah. They disrupt how neurons function and communicate. And something quite stark the notes point out. This neurodegeneration, this damage, might actually be starting, a decade or even more before symptoms become obvious.
A whole decade. Wow.
Yeah, and over time, it leads to that irreversible global brain function impairment and reduced intellectual ability.
Okay, so we know what it is and roughly what's going wrong physically, but why? What about the etiology, the causes?
The notes really stress that it's complex. There isn't one single cause we can point to. It's seen as this complicated interplay. Genetics, environmental factors, lifestyle choices, they all seem to feed into it. But the core mechanism, the notes bring it back to that abnormal protein accumulation we just talked about. The beta-amyloid forming plaques outside the neurons and the tau protein clumping into tangles inside them. These are really central to the disease process described.
And genetics plays a role beyond just, say, having it run in the family. Specific genes.
Yes, definitely. The notes mention specific gene mutations can increase susceptibility. And of course, family history itself is a big factor. Having a first-degree relative, a parent, or sibling with Alzheimer's significantly bumps up the risk.
Right, let's talk more about that risk. Who are the notes saying is more likely to develop Alzheimer's?
They break it down quite neatly into non-modifiable factors, the ones you can't change, and modifiable ones, which you potentially can influence. So non-modifiable. Top of the list is advancing age. It's the biggest single risk factor. Caucasian ethnicity is also mentioned. Family history, like we said, the notes actually put a number on it, 3.5-fold increased risk if a first-degree relative is affected. And then there's a specific gene variant, apolipoprotein E4, or APOE4. That's flagged as an important genetic risk factor, particularly for the late-onset sporadic type, which is the most common form.
Okay, age and genes, things we can't control. What about the modifiable side? What levers can potentially be pulled?
Yeah, this is where it gets quite hopeful, potentially. The notes suggest these modifiable factors might contribute to as many as a third of cases. So things like cardiovascular risk factors are big here.
It's like blood pressure, diabetes.
Exactly. Diabetes, hypertension, obesity, especially obesity in midlife. The notes say that increases risk by about 60%. And then lifestyle habits, smoking, physical activity levels, diet, and interestingly, how mentally and social active you are.
Physical activity makes a difference.
A big difference, apparently. The notes quote, a potential 50% risk reduction with high physical activity. That's quite something. And the idea is that keeping your brain busy, cognitive stimulation, social interaction, intellectual pursuits, even higher education, it seems, to build up what they call cognitive reserve.
Like a buffer.
Sort of, yeah. More capacity to cope with the underlying brain changes before symptoms show. Though, it's worth noting, the notes do mention the link between smoking and Alzheimer's risk is presented as somewhat unclear in the material they reviewed.
It really shows how connected everything is: heart health, lifestyle, brain health.
Okay, let's go back to the brain itself. The pathophysiology. How do those risk factors translate into the actual damage?
So the core process described is this progressive loss and, well, degeneration of brain neurons. It happens particularly in areas vital for memory and thinking, like the hippocampus and the cortex. And this neuron loss is intrinsically linked to those abnormal proteins forming deposits, the beta-amyloid plaques building up between the cells and the tau tangles forming inside them.
So it's the plaques and tangles causing the damage, or a result of it, or both.
It's complex, likely both contributing in a cycle. These deposits, along with inflammation and oxidative stress, which is like cellular damage from unstable molecules, they basically disrupt how brain cells work and talk to each other.
Leading to the symptoms we eventually see.
Exactly. That disruption is what primarily affects memory, cognition, and behavior, according to the notes. They also list inflammation, oxidative stress, and impaired neurotransmitter signaling, like with acetylcholine, as key contributing factors to the overall dysfunction. Okay, now, if someone comes in with memory issues, confusion, it's not automatically Alzheimer's. How do you tell it apart from other things? What's in the differential diagnosis section?
This is really crucial because the notes highlight that telling early Alzheimer's, apart from just, normal age-related memory slips, can be tricky initially. So they list other types of dementia you have to consider. Things like vascular dementia, often linked to strokes or blood vessel problems. Lewy body dementia, which often has Parkinson's-like features and visual hallucinations.
Right.
Frontotemporal dementia, which tends to hit personality and language earlier. And dementia associated with Parkinson's disease itself. They can look similar sometimes.
But aren't there also conditions that aren't dementia at all but can look like it?
Yes, absolutely. And this is perhaps even more critical because some might be treatable. Notes call these the mimics. Depression is a big one. It can cause what looks like dementia, sometimes called pseudodementia. Also, thyroid problems, vitamin deficiencies, particularly B12. Side effects from certain medications can cause confusion, normal pressure, hydrocephalus, or NPH, and hypothyroidism, again specifically mentioned.
That's quite a list of things to rule out.
It is. And the notes emphasize that diagnosis isn't simple. It involves a really thorough clinical evaluation, detailed cognitive tests, brain scans like MRI or PET, and lab tests, all designed to piece the puzzle together and differentiate Alzheimer's from other dementias and these important mimics.
And how common is it? What do the epidemiology notes say, particularly for the UK?
Well, it's framed as a major public health issue. Unsurprisingly, it's much more common in older people. The risk climbs steeply with age. The UK figures cited are around 520,000 people affected specifically by Alzheimer's. And thinking more broadly about dementia, the notes say about 1 in 14 people over 65 in the UK has some form of dementia.
And Alzheimer's is the biggest chunk of that.
Yeah, roughly 2/3 of all dementia cases are thought to be Alzheimer's. It affects both men and women. And, as people are living longer, the overall number of cases is expected to keep rising. The notes also make a distinction between sporadic Alzheimer's, that's the common type, occurs worldwide, complex causes, and familial Alzheimer's. That one's rare, caused by specific inherited gene mutations, usually starts much earlier in life and follows an autosomal dominant pattern.
Okay, so we know it's common. What does it actually look like in a person? What are the typical clinical features described in these notes?
Right, the symptoms. The classic early sign is usually progressive memory loss, especially for recent stuff, forgetting conversations, appointments, that kind of thing. Then you start seeing difficulty with problem solving, planning things out, confusion, maybe getting lost in familiar surroundings, disorientation.
Language problems, too.
Yes, definitely. Difficulty finding the right words, following conversations. Mood and behavior changes are common, maybe becoming withdrawn, irritable, anxious, or depressed. Losing interest in hobbies or social activities. As things progress, difficulties emerge with basic self-care, bathing, dressing, eating. Communication becomes more challenging, decision-making gets harder, managing day-to-day life becomes a struggle. The notes also add things like personality changes, sometimes agitation or a tendency to wander. The key thing is it's progressive. These symptoms get worse over time, leading to really significant impairment.
So with that picture in mind, how is the diagnosis actually confirmed, according to these notes?
The notes state it's primarily a clinical diagnosis. It's based on identifying those characteristic patterns of cognitive decline, short-term memory, language, visual spatial skills, praxis, which is carrying out learned movements. And crucially, it's a gradual decline over months or years. Something really highlighted as vital is getting a collateral history. That means talking to family members or close friends. They often notice the changes first or can give crucial context. The diagnosis process often kicks off because a relative raises concerns.
So it's not just testing the patient in isolation.
No, definitely not. That wider perspective is key. The notes then outline specific criteria. For probable Alzheimer's disease, you need dementia confirmed clinically or with tests, problems in at least 2 cognitive areas, a slow, insidious start over years with worsening, no disturbance of consciousness, and no other systemic or brain disorder that fully explains it. Possible Alzheimer's might be diagnosed if the onset or course is a bit unusual, or if there seem to be other causes mixed in. And they also cover mild cognitive impairment, or MCI, due to Alzheimer's. This is like a pre-dementia stage. There's concern about cognitive change, some objective evidence of impairment, but the person is still functionally independent. They don't meet the full dementia criteria yet. They mention newer terms like mild neurocognitive disorder from DSM-5-2.
What about tests? What investigations back this up?
Okay, investigations typically used in the UK according to the notes. A full medical history and physical exam are standard. Cognitive assessments like the MMSE mini mental state exam are used for screening. But the notes stress MMSE is a screen. It's not diagnostic by itself. More detailed neuropsychological testing might be done.
And brain scans.
Yes, brain imaging. MRI is often used first, mainly to rule out other things like strokes, tumors, or look for signs of vascular changes. PET or SPECT scans can show specific patterns of brain metabolism reduction typical of Alzheimer's, but they aren't always essential for the diagnosis. And finally, lab tests are crucial to exclude those mimics. These like a full blood count, electrolytes and kidney function, UNEs, calcium, thyroid function tests, checking B12 and folate levels, hematinics, and maybe an ESR for inflammation. A chest X-ray or urine test might be done if an infection is suspected, as that can worsen confusion.
Okay, diagnosis made. What about management? The notes say no cure, so what's the focus?
You're right, that's the clear message. No cure currently. So management is all about supportive care. Trying to optimize cognitive function as much as possible, manage symptoms, and maintain quality of life for both the person and their family. It's described as a multi-pronged approach. There's medication, there are non-pharmacological interventions. Crucially, support services for everyone involved, and links with specialist dementia services and community support.
Let's talk about the medications first. What's used?
The notes list the main approved drugs. Firstly, the acetylcholinesterase inhibitors, often called AC inhibitors. Examples are done. Pesal, rivastigmine, galantamine. They boost levels of acetylcholine. The other main one is memantine. It works differently on NMDA receptors. The notes suggest these drugs can provide some clinical benefit, help with symptoms, for maybe 6 months up to a couple of years.
Do they mention side effects?
Yes. Common ones listed are GI upset, like nausea or diarrhea. A rash can occur with a rivastigmine patch. And memantine can cause drowsiness or dizziness. In terms of guidance, ATE inhibitors are usually recommended first line. Memantine tends to be for moderate to severe stages, or if someone can't tolerate the ACE inhibitors. It can also be added on top of an ACE inhibitor in moderate to severe cases. Starting memantine without trying an ACE inhibitor first usually needs specialist input.
And beyond medication, the non-pharmacological side.
Hugely important, according to the notes. Things like structured group cognitive stimulation programs are recommended, especially for mild to moderate dementia. Memory aids and strategies can help. CBT might be useful if there's coexisting depression or anxiety. For managing challenging behaviors or anxiety and agitation, the focus is often on non-drug approaches first. Things like aromatherapy, music therapy, pet therapy, exercise are mentioned, getting volunteers involved, keeping people engaged.
And thinking longer term, palliative care must be crucial.
Absolutely vital. The notes stress the need for comprehensive support as the disease progresses, including good access to palliative care. They touch on difficult aspects like nutrition encouraging oral intake, but specifically stating peg feeding, tube feeding isn't recommended in severe dementia. Decisions about withholding nutrition need to follow legal and ethical frameworks. Managing fevers, deciding about antibiotics, palliatively, these are individual decisions focused on comfort, and resuscitation decisions. Very complex. Guided by advanced directives, family views, frameworks like the Mental Capacity Act, and Resuscitation Council guidance. All needs careful discussion and clear documentation.
What's the general outlook then, the prognosis, according to these notes?
It's described as variable. Depends on things like age at onset, general health, how quickly the disease progresses for that individual. but it's consistently described as chronic and progressive. It leads to a gradual decline. The notes give an average life expectancy after diagnosis of around 48 years, but they do add that some people live much longer, potentially up to 20 years, so there's quite a range.
So it varies a lot person to person.
It does. Treatment response, the quality of care and support these things influence outcomes too. But ultimately, the notes state it leads to significant impairment, loss of independence, and the need for full-time care eventually.
And finally, what about complications? What problems can crop up along the way?
As the disease gets more advanced, various complications are common. Increased vulnerability to infections is a big one. Pneumonia, UTIs are frequently mentioned, often due to reduced mobility or difficulty with hygiene. Falls and injuries are another major concern due to problems with balance, coordination, maybe judgment. Malnutrition and dehydration can happen if eating and drinking become difficult. Medication mismanagement is a risk too. Behavioral issues like agitation or aggression can be very challenging, and the difficulties with basic activities of daily living, bathing, dressing, eating become more pronounced. And the notes explicitly mention the significant burden on caregivers, the psychological distress they can experience. So managing complications is about prevention where possible, monitoring closely, and addressing symptoms promptly to keep the person safe and comfortable while also supporting the carers.
Wow, okay, we've covered a huge amount there, digging right into these MSRA notes. From the basic definition, the brain changes, right through to complications and prognosis. It's clearly a condition with a massive impact.
It really is. I think understanding that core pathology, the plaques and tangles, the neuron loss, and how that creates such a wide range of symptoms is really fundamental. And remembering those mimics the importance of ruling out treatable causes. That's such high-yield stuff for anyone revising or working in healthcare.
Yeah. And I think what also comes through strongly from the notes is the journey. It's not just about the person diagnosed, but their whole family, their caregivers. That emphasis on broad support beyond just the medical treatment really hits home.
It does. And maybe a final thought for you listening, building on that. Think about that challenge we touched on. That often gray area between what might be considered normal aging and the very earliest subtle signs of Alzheimer's. It really raises questions about awareness, about when to seek advice, when to push for investigation, something worth mulling over. Now, if you are revising and found this useful and you're looking for more high-yield resources structured like this, do check out passthemsra.com.
And there's also freemsra.com for more resources. Thanks so much for joining us for this deep dive into the notes on Alzheimer's disease. We really hope breaking it down this way has been helpful for your understanding.